background. Hello. So, being from the nursing background, we all know what is the importance of blood sugar or measuring blood sugar in ICU. You know what are the complications of hyperglycemia or hypoglycemia, how an acute episode of a severe decrease in blood sugar will cause the alteration in the prognosis. So, what I tell to my students or doctors or nurses, that whenever you see any patient whom you think will necessitate the admission to ICU or will deteriorate, just do four things. Whether you are in the ward or in the ICU, just do four things: ABG, ECG, random blood sugar, and chest X-ray. And this will help you in ruling out more than 90%, if not more than 90% of the acute issues. So that is the importance of blood sugar in ICU. And now, without wasting time, I will introduce to you today's speaker, Dr. Vishal Gupta. He is heading the Department of Critical Care Medicine at Sarvodaya Hospital, Noida Extension, UP. It's just adjoining the Delhi, so you can call it NCR. And he has been our old friend and colleague. Over to you, Dr. Vishal.
Thank you, Dr. Ashutosh Bhardwaj. So thanks ICCM for providing us the opportunity to present our topic, glycemic control in ICU, in this wonderful structured program created for the nurses. So let's start the topic. So of course, the nurses are the heart of the healthcare. So for being the ICU nursing is not for everyone. It takes a very strong and intelligent and compassionate person to take on the ills of the world with a passion and purpose and work to maintain the health and well of the planet. No wonder you are exhausted at the end of the day. So now for our topic, glycemic control in ICU. So proper glycemic control forms the backbone of care in critically ill patients. So glycemic control in the ICU in the hospital is very challenging. We have to maintain a balance between hyperglycemia and hypoglycemia. We have to keep the patient in a euglycemic condition, as both of the hyperglycemia and hypoglycemia are the independent risk factor for the morbidity and the mortality of the patient. So for the hypoglycemia is present in approximately 80% of the patients in the ICU. And it is associated with a very poor clinical outcomes like delayed wound healing, increased risk of infections, increased length of stay in ICU and hospital, and there will be an increased mortality rate if sugar is very high. So we have to maintain the euglycemic condition. So what are the causes of hyperglycemia in critically ill patients who are admitted in the ICU? The first is the increase in the glucagon and the cortisol hormones. They are the counter-regulatory hormones for the insulin. They are increased in any of the stress generated in the body, either due to infection or any other cause. And the second cause is the insulin resistance. There is a decreased uptake of insulin of the glucose at the liver entry. And if any patient on a steroid therapy, for example, in COPD patients, we used to give corticosteroids. In a septic shock patient, we used to give hydrocortisone to maintain the BP. The steroid causes increase in sugar by gluconeogenesis. Or any patient who are on dextrose containing fluid like dextrose 5%, dextrose 10%, or DNS. And the patient who are on enteral nutrition and who are on total parenteral nutrition. And of course, the ICU patients are bedridden, so there is a decreased physical activity which causes decreased uptake of sugar in heart and skeletal muscle. So these all are the causes of increased sugar in critically ill patients. Now, what is the pathophysiology? What does the high sugar does to body? So any metabolic stress response, like I said previously, the infection on any surgery, on any other thing, they causes increase in the stress hormones. Stress hormones, I already told you, the counter-regulatory hormones are glucagon, growth hormone, and So what they do, they increases the glucose by gluconeogenesis and glycolysis, and it causes decrease in insulin. So increased sugar causes immune dysfunction, they causes increased ketones, and ultimately they leads to cellular injury, apoptosis, inflammation, tissue damage, and altered wound repair, acidosis, and infarction or ischemia. So it all ultimately leads to prolonged hospital stay, disability, and death. Now, how to approach the hyperglycemia in ICU? In ICU, the blood glucose is measured by the glucometer. We all know it is a point of care test. We used to check the capillary blood sugar by pricking the finger. So it is checked routinely on arrival of the patient in ICU and every 4th hourly if patient is on RT feed, enterally fit patients. And second hourly in those patients who are NPO in medical or surgical ICU, or 1 hourly in those patients who are on insulin infusion or who are going hemodialysis. Now, this is the first question. So anyone can answer in the chat box. Now, what will be the next step if the RBS blood sugar is 240 milligram per deciliter in a sepsis patient who is on ventilator? The first option is start insulin infusion as sugar is high. Second option is wait for the next reading of the sugar and then decide about the insulin. Third one is to ignore. And fourth is ask sister to repeat it immediately as there is a higher suspicion of false reading. So what is the answer?
Somebody has put A, start insulin infusion. So you can, change your phone name to your name. It would be easier for us to recognize because the phone model number is coming.
Yes.
So Xiaomi has answered A.
Yes.
Then Abrunoi 4, Khushbu 2.
Yes. So Khushbu is right. So we should not start straight away with a single reading of high sugar. We have to wait for the next reading of sugar after 2 hours or 1 hour. We can repeat it, and then we should decide if it is high. Then we should start the insulin infusion. So answer is wait for next sugar reading. Okay, and start the insulin infusion if second reading is also high. Now,
here if the blood sugar,
sorry,
yeah, I just want to add one point that if the blood sugar has been more than 300, then straight away you go for IV insulin.
Yes. So what should be the target blood sugar in ICU? So according to Surviving Sepsis Guideline 2021, they have told that the RBS should be in the range of 140 to 180 milligram per deciliter. And the other associations like American Diabetic Association and Nice Sugar Trial and American College of Endocrinology, they also have told that sugar should be less than 180. And we should not control we should not be very strict in controlling the sugar, as there are some trials in early years. They have told that by keeping the sugar in the range of 80 to 110, we can prevent the mortality, we can decrease the mortality of the patients. But in that trials, we have seen that there are more risk of hypoglycemia. So ultimately, they can lead to increased hospital mortality. So we should not be very intense in sugar control. We should keep the sugar in the range of 140 to 180 only. Now, hyperglycemia in ICU is treated with subcutaneous or intravenous insulin. The subcutaneous insulin we used to give in stable patients who are eating, and IV insulin we are used to give in NPO patients and in patients who are unstable. So for short, we have a short-acting insulin, also known as regular insulin, which is given as subcutaneous also and intravenous also. And the long-acting insulin like Glargine, they are used as a subcutaneous dosing only. They are the basal insulins. So when the subcutaneous insulin is used, the blood sugar should be checked after every 4th hourly or 6th hourly. Or 6th hour we can say pre-meals plus 10 p.m. All the pre-meals or breakfast, lunch, and dinner, and at the 10 p.m. And when IV insulin is used, we should check it every hourly, the sugar, and 2 hourly if stable for 3 consecutive readings. If 3 consecutive readings are below 180, then we can check it every second hourly. So IV insulin half-life is only 5 to 9 minutes. That's why in ICU it is said that in unstable patient we should use IV insulin only. So as his half-life is 5 to 9 minutes, so it allows rapid reversal of hypoglycemia if it occurs. So by giving the subcutaneous insulin, its half-life is almost around 5 to 6 hours. So we should avoid that. And for IV insulin, we should be very careful in giving the insulin in the impaired mental status patient, as we can skip the hypoglycemia in this type of patients and in renal failure patients. In renal failure patients, the insulin takes time to excrete. Now the second question. During monitoring, during morning rounds, the doctor found that patients' RBS remains persistently high during night on an insulin infusion. So what can be the reason?
Somebody wants to
That's you have to
talk or
write
give
it.
question. If somebody wants to give answer, they can raise the hand. You can allow for short time to speak.
No answer. I think I should proceed.
Yeah, sure.
Yeah. So the patient RBS was persistently high throughout the night. So the reason would be the nurse has not changed the scale to higher one. The scale we make for the insulin requirement to increase if the sugar is not in that range. Okay. Now, third question is, what if the sugar remained high even on highest scale in the previous patient? We have increased the insulin, but sugar is still high, and we have reached to the maximum of the insulin requirement, but the sugar is not in a normal range. So what could be the reason for that? Okay.
Again, steroid. Steroid is their favorite. So every question answer cannot be steroid.
Yeah, answer should not be the steroid because it can be did not change algo.
Algo.
Okay.
Maybe one reason, yeah.
Yeah, maybe one reason.
That's
Stress. No, stress is not the answer. Okay. So we can go to the another algorithm. But the best answer is we have to change the insulin vial. We have to see. So the insulin vial can be the not effective. So we can change the insulin vial. This happened with me once in the hospital. So we have reached to the second algorithm. Also, the sugar was not coming down. So we have changed the insulin vial, and it came down within a means 1 hour with a minimum dose of insulin. So vials,
maybe
yeah. Sorry.
yeah. And maybe the insulin is not going into the blood. That also you have to check.
Right. Okay. So now insulin concentrations should be standardized throughout the hospital. The regular insulin should be in the concentration of 1 unit per ml, and we should make a protocol to control the RBS. So ideal protocol, what is the ideal protocol? The ideal protocol is that which work in a given institution. So all protocol implementation will require multidisciplinary education. Now there are several protocols. One famous protocol is the Yale Insulin Inclusion Protocol. So it has shown some improvement in the control of sugar in the ICUs. But the best protocol is the one which every individual institution has developed. So what they did, they have made a concentration of 1 unit insulin per ml. They have mixed 40 ml of 14 ml of normal saline with 40 units of insulin, and they have flushed the infusion with to concentrate all the IV tubings, and they have initiated what they have done, they have divided the blood glucose level, whatever it comes. For example, they have written that 320, if 325 is the sugar, they have divided it by the 100. So divide the initial blood glucose level by 100, then round to the nearest 0.5 unit for bolus and initial infusion rate. Example, they have given that if the sugar is 325 divided by the 100, it comes out to be 3.25, round it to nearest 0.5, 3.5, and they have given the bolus of 3.5 unit, and they have started the insulin infusion at unit 3.5 unit per hour. Then we have to check the blood glucose hourly until stable, that is 3 consecutive values within the target range. Target range is 140 to 180. So we can do like this, and this is the famous Yale protocol. The other protocols we can implement in our institution, like we have make a regular insulin 40 units in 40 ml of NS, and we start the insulin infusion in the ICU when patient is NPO and the sugar is more than 200, and or if patient is not NPO, is taking food and blood sugar is more than 250. Now, if blood sugar is more than 300, then a bolus injection of regular insulin is given at the we have to calculate it by the 0.1 unit per kg. For 50 kg patient, we have to give 5 unit bolus. Then we should start it with a 5 unit per hour, the infusion with the regular insulin. So if after an hour, if sugar comes below 150, then we have to stop the infusion, or if it is 150 to 200, we should continue with the same rate, or if it is more than 200, we increase the insulin infusion rate by 2 units, and we check it further every second hour only. Now, if the patient is stable, then we can use subcutaneous insulin with the regular insulin, and this all are individualized protocol. We should implement what is the best. Now, the next MCQ. Now, which electrolyte is to be monitored on insulin infusion? First option is sodium, second is potassium, third is chloride, and fourth is bicarbonate. Yes,
Come on,
please
guys.
write.
Yes. I want correct answers from all on this. Very
This
good.
is the okay. Right.
Very good. So everyone has given the correct answer.
Yes. So you all are right. It's a potassium. Now give me the answer why. This you have to write in the chat box. Reason.
So at the end of the lecture, Dr. Vishal, we can, you just be prepared with this answer. Why potassium is the electrolyte to monitor on insulin infusion? Okay.
Okay, right. Okay.
So in the end, people raise your hand and be prepared. We'll talk to you.
Okay, right. So now the next question. A patient in the ICU is on high dose vasopressors. He is on NORAD and vasopressin, and the patient shows persistently low sugar on the glucometer by the finger prick. So what could be the reason? So on high dual vasopressors, the sugar is low by the finger prick. So the reason is that on high blood, or if the patient is hypotensive and is on dual vasopressors, so the perfusion will be hampered in the peripheries. So the metabolism of the peripheral tissues will be high, so glucose will be used in the peripheries. So the perfusion will be low, glucose will be high, will be consumed. So the sugar will be low. So we should not check in this type of patients the finger prick technique. We have to take the blood samples from the arterial line or the central line. We have to check sugar from arterial line or central line. So we should not prick on the fingers to check the sugar in the patient who are hypotensive on dual vasopressors. So specific situations in which the capillary blood sugar will be inaccurate are shock, as I explained in previous question, hypoxia, dehydration, extremes in hematocrit, and the patients who have increased bilirubin. And IV insulin should be transitioned to the subcutaneous insulin therapy when patient begins to eat and blood glucose levels are stable. I will tell you in the next slide how to do it. And because of short half-life of IV insulin, the subcutaneous basal insulin, which I told glargine, should be administered at least 1 to 2 hours prior to discontinuing the drip. So we should give subcutaneous insulin 1 to 2 hours before stopping the IV insulin. So this is the method to convert the IV insulin to subcutaneous one. For example, patient has received an average of 2 units per hour IV insulin during previous 6 hours. Recommended doses are as follows. The subcutaneous total daily dose is 80% of the 24-hour insulin requirement. If a patient has taken 2 units per hour for 6 hours, so we have calculated it for the 24 hours, 2 units per hour. It comes out to be 48, and we have taken 80% of that 48, it comes out to be 38 units. So 38 units subcutaneous we have to use. Now, from this 38, the 50% of the dose, that is 19 units, will be the long acting insulin like glargine. So 19 units of glargine to be given, and the next 50%, 19 units, will be divided into three parts. It will be 6 units pre-meals. That will be the rapid acting like regular. So we have to divide it by this. Now the last question, nurse called doctor immediately in ICU as patient was not responding. He is a known case of diabetes on subcutaneous insulin. He was kept NPO since last 6 hours for a procedure. The sugar came out to be 46 milligram. Immediately 50 ml of D50 given. Patient become conscious and oriented after receiving the dextrose D50. Now what could be the answer?
Everyone knows this answer.
This is very basic one. This is the most basic question.
Very
Yes.
good, hypoglycemia.
Very good. This is hypoglycemia. Why it is happening? Because by mistake, nurse gave the scheduled subcutaneous insulin in an NPO patient. So protocol should be avoid injecting subcutaneous insulin in an NPO patient. Call doctor if RBS is high. Now hypoglycemia. Hypoglycemia by definition is the sugar capillary blood glucose less than 70, but in ICU less than 100 milligram per deciliter is an accepted alert value. So we can expect a downward trend of blood glucose level. So what we should do, stop infusion, give D25 or D50, 50 to 100 ml and recheck in 15 minutes. So we should be very aware if any IV insulin is there. So we should stop oral hypoglycemic agents and subcutaneous insulins, and as both of them are long acting. So who are the patients at risk of hypoglycemia? The renal failure patients and the hepatic failure patients. And if the sugar comes less than 55, it is a neurogenic symptoms like sweating, palpitation, and tremor anxiety happens. And if the sugar is less than 45, it's a neuroglycopenic condition. The brain is deprived of glucose. The patient can throw seizures and he can land up into coma. Now, these are the basic core competencies for nurses regarding to sugar monitoring. The bedside glucose monitoring technique they should know. The critical and target blood gas values they should know. They should be aware of insulin administration technique, the optimum timing of subcutaneous insulin shots, hypoglycemia prevention and treatment, blood glucose and insulin dose documentation. And the last basic page. Now, this is the famous Florence Nightingale. The nature alone cures. What nursing has to do is to put the patient in the best condition for nature to act upon it. So thank you very much. Any questions?
Thank you, Dr. Vishal, for such a clear and a simple and basic talk for our nurses. I think you have made things very, very clear that what are the targets of blood sugar, what to do when the patients are NPO, how to calculate the dose of Lentus or glargine, insulin, what are the signs and symptoms of hypoglycemia or hyperglycemia, all that you have covered. So the question which remains was the role of insulin in potassium metabolism.
Yeah.
So will anyone try to answer this?
So why
You can raise your hand.
potassium is important in the patient who is on insulin infusion? Dr. Ashutosh, whatever I felt in the last 12 to 15 years of my practice, whatever the common problems I felt in the ICU in regarding the glycemic control, that I have put as a MCQs in the yeah.
Great.
Whichever hospital I have went, I have seen some problems and I have just taken that as an MCQ. So these are the basic problems which we face in the ICU.
I saw that. All things were very practical. All things were practical. So there is a question for you, for patient who will undergo surgery. What will be our target RBS?
Yes, for these patients, we should keep the RBS from 100 to 140 milligram per deciliter in the patients who are undergoing surgery. So this is the recommended one. In medical ICU or in the patients who are sick in surgical ICU, they have developed some kind of infection or stress there, then we have to keep the target 140 to 180 in the in critical ill patients. Yeah, someone has written answer. Yes.
Sahib na roi, huh? Very good. Shabash.
Very good. Yes.
So this is the correct answer. So is there any other question from the audience? We have still left with some of the time, so you can make use of it. You can ask questions related to blood sugar management in ICU or in wards, or maybe in surgical ICU or other ICUs.
So let me ask question. What does this potassium hypokalemia does in a patient if the potassium goes down? Anyone can answer? Because of insulin, there is a hypokalemia. The potassium goes down. Then what does this condition does to the body? Hypokalemia. Which is the most important organ affected in hypokalemia?
Your point of concern in hypokalemia, guys. I can see very good answers from all of you. So this again, if someone wants to raise hand, kidney. So Amrita is saying kidney. But will that cause any acute issue, Amrita?
Oh my God, pancreas. Oh. Any more? Anyone can answer better? Better answer I need. Oh my God, brain.
Kidney, pancreas, brain, liver. So what else is left? Maybe that is the answer. Any other major organ which is left is the answer. Yes, so this is the answer. So you have got your, Dr. Vishal, you have got your answer, by method of exclusion.
Right. Huh? So,
you can explain to them.
Yeah, so hypokalemia causes arrhythmias. So arrhythmias occur through the heart. So potassium channel get affected. The sodium potassium interaction, the channels are there in the heart, and there will be a decreased entry of the potassium inside the heart, and it will cause arrhythmias. So the heart is the organ affected. So any questions?
Any other question? So I have one question for my audience.
Yes.
So in a given scenario, if you are given a choice, what will you like to have in your patient? You are bound to have one. Let me assure that. Whether you will like to have hypoglycemia or hyperglycemia.
Good question. So I
For
can
a patient of yours,
so I
you
can
would like to have.
I
Yeah,
can
yeah, yeah.
simplify
Please
the
go ahead.
question. Which is more dangerous, hypoglycemia or hyperglycemia?
Hyperglycemia is the answer from Kushbu. Any other answer? How many for hypoglycemia and how many for hyperglycemia? Kushbu is saying, so what is the reason? Why hypoglycemia? Hemlata or Kushbu? Patient may go to shock with blood sugar low. No, low blood sugar is not a reason of shock. Yes, very good.
Good.
So our brain is dependent on solely on the blood, on the glucose, mainly on glucose. So once the blood glucose falls to a critical level, you will have the permanent damages, which starts happening very soon in the brain. Maybe in 3 to 4 minutes or 5 minutes, you will have permanent hypoglycemic damage in the brain cells. And once the brain cells are dead, they are permanently dead or inactive. They will never be alive again. So that causes permanent damage. So it is better to have hyperglycemia than hypoglycemia in your patients. So patients who are on insulin, any patient who are prone for hypoglycemia, you all must have a very vigilant and close observation on all those patients. That hypoglycemia should never happen in a patient. Hyperglycemia, maybe, if that is happening in a patient, is acceptable to me, but hypoglycemia for long, maybe 3 to 4 minutes or 5 minutes, which is nothing in in your duty span of maybe 8 hours. So if that happens, you don't look at the blood glucose levels when the glucose levels are falling. That may, the whole picture may change. Once your patient's brain is not working, there is no fun working on the other organs. You all must have encountered such cases where brain damage happens because of low oxygen, hypoxemic damage or hypoglycemic damage. So that is my message for you. So if there is no question, we can wind up, Dr. Vishal.
Yes, sure. Deepa?
Yes, sir.
Yeah. Okay,
I
one
have
question.
doubt. So there's one. Yeah, sir, I have doubt. Patient potassium is 4.8 and blood sugar is 467. So you will start uh, the insulin infusion on this patient, and then you have to monitor the blood potassium levels, serum potassium levels also. So your target is to keep, yes, the insulin, you have to give the insulin, and at the same time, you will have to keep an eye on the potassium levels. So maybe, you can send, if the risk of hypokalemia is very high, you can send the serum potassium levels little quickly or frequently, maybe 4 hours or 6 hours or 8 hours, depending on the patient scenario. That can be decided by the doctor. Or insulin has to go on, yes. So how come the serum ketone of 0.2 is important? I don't know the name. The phone name is there, Xiaomi. How is it important? Serum creatinine 0.02. When you have blood sugar of 467 because of any reason, okay, you have to
Right.
give insulin. And once any patient is on insulin, you have to closely observe and check and monitor the potassium level.
Right.
Okay.
Okay, Deepa, can we conclude?
Yes, sir. Just wait for 2 minutes. Let's see that any questions are coming. If not, then we can end the session.
Okay, right.
Okay, sure.
So we wait for 2-3 minutes. Let's see if any question is coming.
Okay, right. So, any other question from the participants?
Yes, sir. In chat box, there is a message that no, sir. So thank you. Thank you, Vishal, sir. Thank you, Ashutosh Bhardwaj, sir. We will end the session now.
Okay. Thank you, Deepa, and all the participants to listeners. Thank you very much. Thank you, Dr. Ashutosh.